All right. Welcome. Good afternoon, everybody. Thank you for being here with us in our second webinar of NHHAD 2021. My name is Luis Mares, and I am the Director of Community Mobilization at the Latino Commission on AIDS. And today I will be your host and your moderator for this webinar. Today's webinar is titled The Impact of Hepatitis C in the United States, in which our presenter, Dr. Bradley, will discuss the impact of hepatitis C in the United States with the specific insights of the impact in the Latinx community. This webinar will provide you with information about HepVu and hepatitis C in our country, information about demographics of hepatitis C in the country, and also an overview of hepatitis B, HepVu, and how the website works. There will be a section at the end for questions. So please, I encourage you to write your questions in the Q&A box so we can read it later at the end. This webinar is also being recorded, and this recording will be shared with you at the after the webinar is completed. Sorry for this. The NHHAD National Hispanic Hepatitis Awareness Day is like a national awareness campaign that the Commission created in 2012, which makes this year the 10th campaign. The goal of this campaign is to create awareness within the Latino community about the impact of hepatitis A, B, and C, viral hepatitis, in the community, and the tools that we have available for solve this problem, this epidemic. As you see in the previous years, we have produced different posters. We focus on different things. The last year we was about prevention mostly. But this year, we wanted to do a little bit something different, and we treat the hepatitis as a crossword puzzle, something difficult sometimes to resolve. And we always think that we see one of these things and we think, it's impossible, we are not gonna make it. But if we try, sometimes we can solve it. Most of the times we can solve it with some little help. So it's the same with viral hepatitis. We think that it's a problem that is existing for a long time here in the States and we cannot solve it, but yes, we can, especially now that we got tools, as you can see in the poster. We can get tested for all of them, and we can find the people that is carrying this virus and be treated. And those who are not infected with viral hepatitis, they can get vaccinated against hepatitis A and B, or to prevent hepatitis C, there's also measures like harm reductions. There is treatment for hepatitis B and hepatitis C, and even a cure for hepatitis C, which has changed lately. And this year, because of the topic, we had a viral hepatitis crossword puzzle challenge, and I'll let you know that we already chose the 3 winners of the people. Thank you very much for all of you who participated, and we are going to send an announcement of the winners in the following days. Also, I wanted to let you know that all the people who live in New York, tomorrow there is a webinar organized by HepFree NYC, a coalition of organizations that works in the area of hepatitis in New York City. And the topic is going to be addressing access to hepatitis care. It's going to be a panel. And for those who like to know about incidents and data on hepatitis in Latinos, you can download the fact sheet that you see in the slide in our website, HispanicHepatitisDay.org. As I mentioned, today's presenter is Dr. Bradley, who is an assistant professor of epidemiology and biostatistics at the School of Public Health at the Georgia State University. And now I'm going to stop sharing my screen, and Dr. Bradley will share her screen. Okay, as I mentioned, that's the topic, and we're going to touch some information on Hispanic. Just to tell you know about the commission, the Latino Commission on AIDS was founded in 1990. We had over 30 years of working with the Latino community, trying to improve the health of the Latino community, not only through programs, but also through advocacy and policy work. We started working on the area of HIV and AIDS back in the 1990s, but we have grown to cover different health inequities that affect our community. It's a nonprofit organization. We are based in New York, but we have a national reach, and we have offices not only in New York, but in North Carolina and hubs in Florida and Texas. As I mentioned, the Hepatitis Awareness Month Hepatitis Awareness Hispanic Day is on May 15, and we chose it to be the middle of the Hispanic Awareness Month and just before the hepatitis testing day that happens on May 19. I already spoke and told you what the goal of this campaign is. We create awareness within the Latino community about the impact of viral hepatitis. The hepatitis C epidemic is a leading cause of liver, we know, for all America, and real cause of mortality. It's the silent killer. There's millions of people that are living with hepatitis C, 2.3 million people, and half of them do not know they're carrying this virus. And hepatitis C and other infectious diseases are often overlooked consequences of American opioid crisis. There's a link between opioid use, intravenous drug use, and not only hepatitis C, but hepatitis B and also HIV. And with the recent increase on the opioid epidemic, we have also seen increases on these diseases. Among Latinos and Hispanic or Latinx community, the chronic liver diseases is one of the mainly the causes of death within us. Chronic conditions of hepatitis or liver are not only caused by hepatitis, but the main cause of cancer, for example, is viral hepatitis. And they're among the 10 leading causes of death among Latinos. The rate of chronic liver disease among Hispanic men and women is double than the white counterpart. And it's the third leading cause of death among Hispanic men ages 15 to 64 in 2015. And to monitor and effectively address the hepatitis C epidemic, there is a need for better surveillance data to inform policy programs and resource planning. In the States, as we know, there is an amazing surveillance program for HIV. It's not the same for hepatitis, and we are advocating and asking for a better surveillance data for hepatitis. So now, Dr. Bradley is going to continue with her presentation about HepVu and hepatitis C in America.
Thank you so much for that nice introduction. Good afternoon, everybody. I'm Heather Bradley, and in addition to being an assistant professor of epidemiology at the Georgia State School of Public Health, I'm also the project director for HepVu. I'm excited to be here. It's always great to be with this group and to talk about our hepatitis C data visualization platform, and also just to tell you a little bit about some of the data available on HepVu. So HepVu is an interactive online resource for those of you who haven't interacted with us before that visualizes the hepatitis C epidemic in the US. For those of you who may be familiar with AIDSView, we've used the infrastructure developed for AIDSView to develop data visualization for hepatitis, which, as you all probably know, is another area where data is needed for public health decision-making. So like our sister site, AIDSView, HepVu works to make data widely available, easily accessible, and locally relevant to inform public health decision-making. We launched the HepVu resource in 2017 with hepatitis C estimates at that time from 2010. So one of the challenges, which Luis sort of just alluded to with hepatitis C, is that we don't have a robust national surveillance system for hepatitis C, like we do for some other infectious diseases, like HIV, for example, where all cases are reported at the state level and then to CDC. And so to help meet a need for understanding the burden of hepatitis C infection at the state level, researchers from the Emory Coalition for Applied Modeling Project, together with Dr. Eli Rosenberg from the University at Albany, developed model-based estimates, first for 2010, that were the first of their kind, and really started to allow us to compare hepatitis C burden from state to state. So those estimates have since been updated and stratified by sex, age, and race. And we've also recently added mortality data now all the way down to the county level. So those are some of the data that I'll present today. The modeling work that I talked about and resulting estimates that I'll present today are supported by and in collaboration with CDC. And HepVu is powered by AIDSView project, which is led by my colleague, Dr. Patrick Sullivan at the Emory Rollins School of Public Health in partnership with Gilead Sciences. So HepVu's core mission really is to provide data visualizations and related insights to catalyze research on public health issues related to hepatitis. One of our main goals is to present data that policymakers, researchers, advocates, and others can use to strategically plan interventions for hepatitis prevention and treatment, to allocate resources toward those interventions, and of course, to monitor progress toward public health goals. Maps that are currently available on the site include state-level hepatitis C prevalence estimates and mortality data from 2013 to 2016. You can view these as overall state estimates, or you can look at them by sex, age, and race. We also, as I mentioned, now have hepatitis C mortality data from 2017 that are mapped now down to the county level. And alongside these data, you can view 3 state-level opioid indicators to really visualize the relationship between hepatitis C infections and the opioid epidemic. And I'll be talking a little bit more about that later in the presentation. So the opioid indicators that we have are also listed here: the opioid prescription rate from 2017, the drug overdose mortality rate from 2013 to 2016, and then we have the pain reliever misuse rate from 2015 to 2016. I will say that we're in the process now of actually updating these opioid indicators to the most recent data. Something to look forward to next week, we're also going to be releasing new data around hepatitis C treatment restrictions. We actually have a webinar on treatment restrictions planned for tomorrow, so come on over to HepVu and register for that webinar to learn more about what these treatment restrictions look like at the state level. And then we'll be launching, of course, those maps on the site to follow. So I'll move on now to discuss hepatitis C prevalence estimates that are currently available in HepVu. So we currently map modeled estimates of hepatitis C prevalence at the state level by sex, age, and race. And I'm going to sort of walk through these groups one at a time, but the main messages from this set of maps is really that from 2013 to 2016, hepatitis C continued to disproportionately impact males, the baby boomer population, Black Americans, and increasingly young people in states that are highly affected by the opioid epidemic, likely as a result of increased injection drug use. So I'll go through these groups one at a time and highlight some of the key findings that you can see on the maps. I'll start with findings by sex. And so the key finding here by sex is that men had about twice the hepatitis C prevalence of women. And this disparity is consistent across states and with previously published estimates. So nationally, hepatitis C prevalence was estimated at 1.3% among men and 0.6% among women. And I'd like you to just note the related infographic displayed here on the right of the slide, which shows these data in a really easily digestible way. And this infographic, along with others, is available for download and use on the site, along with several of the other infographics that I'm going to present today. Okay, so what about by age? Here you can see another relevant infographic available on the site on the right side of the slide. And this infographic is showing that hepatitis C infections are more common among young people in states highly affected by the opioid epidemic. So we looked at hepatitis C prevalence among 3 age groups, baby boomers, and then groups of people who are both younger and older than baby boomers. Baby boomers continue to have the highest burden of hepatitis C of the age groups that we assessed. And in fact, about 71% of all hepatitis C infections were still among baby boomers in the US. In terms of prevalence, we estimated about 1.6% prevalence among baby boomers. But in many states, we saw that estimated hepatitis C prevalence among this age group was nearly 2% or higher. So we do see a fair amount of geographic variation here. We do see much lower prevalence among young people compared to baby boomers overall. So baby boomers had about 3 times the hepatitis C prevalence of people younger than 45, but we see higher prevalence among young people in states, as you can see here, that have been really hard hit by the opioid epidemic. So notably Kentucky, New Mexico, Oklahoma, and West Virginia. where prevalence in this younger age group was at least twice the national average. And so, as you can see on the infographic here on the right, these states also had some of the highest opioid prescription rates in the country during the same time period. So the last comparison I'll show today is hepatitis C prevalence by race. And the main comparison that we made in this particular model was between non-Hispanic Black persons and persons of other race ethnicities. So we did see hepatitis prevalence that was more than twice as high for Black Americans compared to non-Black Americans. And we estimated prevalence respectively at about 1.8% and 0.8%. So a really startling way, I think, to communicate this finding is that although Black Americans comprise only 12% of our country's population, they represented 23% of prevalent hepatitis C infections during this time period. And this disparity was even larger in certain geographic locations, and you can start to sort of see that from the map here. There were 9 US states where hepatitis C prevalence among Black Americans was 4 or more times higher than among non-Black Americans. So unfortunately here, this comparison by race had to be limited to non-Hispanic Black Americans and persons of all other race and ethnicity combinations due to really insufficient levels of widespread and publicly available hepatitis C surveillance data, which, as Luis said earlier, is something that we continue to advocate for. We do see using the NHANES data alone that national hepatitis C prevalence was about 0.8% among the Hispanic Latinx population compared to 1% among the non-Hispanic white population. So about the same or a little bit lower. But it's important to point out that despite these slightly lower rates of hepatitis C prevalence, the Latinx community sees much worse hepatitis C related mortality outcomes compared to non-Hispanic whites. And this includes liver cancer and mortality attributable to hepatitis C. And so as Luis alluded to earlier, liver disease is currently the 7th leading cause of death among the Latinx population in the US. Because the analysis that we focused on for these maps was really focused on differences in hepatitis C prevalence versus outcomes, we chose to focus on the larger disparity between Black Americans and people of other race ethnicities. But estimation of state level hepatitis C prevalence and related outcomes among the Latinx population is a really important priority for future research and modeling. So now I'll move on to talk about some of the data that we most recently published on our site, which is data on hepatitis C mortality for the first time at the county level. So I'll start by just sort of, explaining, why we felt it was important to map county level hepatitis C mortality. And as everyone here is probably aware, hepatitis C, if it's not detected and treated, can lead to severe liver damage, liver cancer, and even death. And so recent strategic plans by both CDC and the Department of Health and Human Services have identified reductions in the national hepatitis C related death rate as an important indicator to monitor progress toward achieving hepatitis C elimination. And so we know from vital statistics, interestingly, that the national hepatitis C related death rate has declined since 2013 overall, but there are serious disparities in this change across regions, counties, and also by age. We also know that there have been recent shifts in the hepatitis C epidemic, including advancement in treatment options, as well as changes in public health strategies like screening for prevention and control, all of which are likely to impact hepatitis C mortality. And so it's really important for us to be able to monitor and understand, what's happening with hepatitis C mortality in light of these changes. So by visualizing viral hepatitis data by county, health departments, policymakers, researchers, and community leaders are really better able to identify these disparities in outcomes that are geographically driven, and driven by other factors, and then to develop programs and allocate resources to address inequities and ultimately to work toward eliminating hepatitis C. So the hepatitis C mortality estimates on HepVu were produced by a team that I was fortunate to be part of that was led by Dr. Eric Hall and published in the journal Hepatology. And as I said, we estimated hepatitis C mortality at the county level. And so this work, interestingly, indicates that although nationally hepatitis C mortality has been declining since 2013, 1 in 5 or 20% of counties actually saw an increase in hepatitis C related death rates between 2013 and 2017. So major geographic disparities here in hepatitis C mortality or related mortality rates. So this work really highlighted some large disparities, as I said, in hepatitis C mortality around the country. And we found that in 2017, the highest rates of hepatitis C related mortality were primarily concentrated in the West, in Southwest, and Appalachia. We were also able to look at death rates by age and found that among people under age 40, hepatitis C related death was most common in New Mexico, Oklahoma, and Appalachia. And notably, these regions have also been experiencing increases in injection drug use as a result of the opioid crisis, which is likely, explains a lot of this increase, a very unfortunate increase in hepatitis C mortality among young people. Among people over 40, hepatitis C related deaths, however, were most common along the West Coast and in the Southwest. So getting back to using hepatitis C mortality rates as a benchmark for monitoring progress toward hepatitis C elimination, this analysis suggested that only about 30% of US counties had a lower age-adjusted hepatitis C related death rate compared to the National Viral Hepatitis Progress Report's 2023 goal of less than 3 deaths per 100,000 people. And so we've got obviously quite a bit of work to do to get to that 2023 goal in a pretty short amount of time. I want to spend the last few minutes here just talking about some of the visualization resources on our site that are designed to really make the data that I just presented meaningful for people, including data consumers from policymakers to researchers to advocates and patients, certainly. So I want to just show you quickly, we have a new navigation system on the site for those of you who haven't been on the site for a while or have been using a previous sort of version of this. This is what our map looks like now when you go to HepVu and you choose view the map, right? So what I like to tell people is to start here with selected data set, right? So you can choose here what you want to, do you want to look at prevalence? Do you want to look at mortality? Do you want to look at some of the opioid indicators, right? So you'll get a drop down menu here and then you can see if those data are available in terms of rates or cases or both, and you should see that they're available as either rates or cases. And so you can toggle here and choose how you'd like to see the data presented. And then you can see over here on the left whether the data are available at the county level or the state level or both. And so where data are available at both the county and the state level, you can toggle between county and state. And then here next to filters, you'll only see filters here that are available for the data you've chosen. So if those data are mapped by both or by age, sex, and race, you'll see these toggles here to filter on age group, by sex, and by race. And then where you see this data comparison tab here, you can, now that you've chosen the hepatitis indicator map that you want to look at, You can choose data comparison by social determinants of health, like income level or insurance coverage, or you can choose to look at the data alongside one of the opioid indicators that we map. So that's just a quick little tutorial to navigating around our sort of new navigation style. We also have local data profiles for each state. These can be really helpful when you're doing Hill visits or advocacy for a particular state. And so here you can go, you can explore the map by state, click on the state you're interested in, and we'll give you, everything we've got related to that state. And so what you can see by state is hepatitis C prevalence between 2013 and 2016. You can now see hepatitis C mortality for 2017. And then you can see data stratifications for both prevalence and mortality by sex and race. The opioid indicators that I mentioned earlier are all available at the state level. And then we have all of these social determinants of health that are also available to view at the state level. So education, income inequality, percent of households living in poverty, and health insurance coverage. So these are available as descriptors for each state, but you can also, at the state level, look at comparisons, side-by-side comparisons of hepatitis indicators alongside these other related indicators. So we also have 2 deeper look pages, and we'll continue to work on additional deeper look pages. Currently, we have one for resources related to the connection between hepatitis C risk and the opioid epidemic. And then we have another on viral hepatitis elimination plans across the US. So you can really think of these deeper look pages as one-stop shops for all of the resources on our site related to these issues, including infographics, expert guest blogs, local statistics, downloadable data, and maps. And so if you're interested in sort of seeing everything we've got available on the connection between hepatitis C and the opioid epidemic, or on hepatitis C elimination plans, check out those deeper look pages. We routinely publish expert Q&A blogs about various topics related to viral hepatitis and not just hepatitis C. We also feature experts on topics related to hepatitis A and B. These were some of our recent blogs that were published alongside the county level hepatitis C mortality. So we had Dr. Judith Feinberg from West Virginia talking about hepatitis C mortality and morbidity in Appalachia. And then we had Dr. Eric Hall presenting his work on county level hepatitis C related mortality trends in the US. So some of those data that I just presented earlier. But we release these really, if not every month, every couple of months. And so I'd encourage you to check out the site, because there's always something new there from one of our experts who are kind enough to talk with us. We also have a large and growing suite of infographics that we develop for awareness days and data launches. Some of our infographics are also available in Spanish, and so definitely check those out. And these are really excellent resources. Our colleagues at Signal do an amazing job with these, just making data really easily accessible to folks. And so you can download these, you can use them in your own presentations, you can print them out and take them to the Hill, use them in any of your advocacy work. They're very easily downloaded and shared. So use these in any way that you'd like. And then for those of you who like to work with data directly like I do, all of the data on our site can be downloaded for your use. And so you can find the data sets. All of the data that you see mapped on our site can be downloaded directly from the tools and resources section. So I want to just end here by showing you one of my favorite features of the site, which is how side-by-side comparisons of data on the site can be used to tell compelling stories. I mentioned earlier that we've incorporated these opioid indicators to HepVu so that, to facilitate comparisons with hepatitis C prevalence and mortality estimates. And so, most of you, I think, know by now that as part of the opioid epidemic, we've seen, unfortunately, increases in the number of people who inject drugs, and that this more widespread injection drug use seems to be resulting in higher rates of bloodborne infections like hepatitis C, and concerning trends even, in perinatal transmission of hepatitis C. So these are maps of the 3 state-level opioid indicators that we have that can be compared alongside hepatitis C prevalence and mortality on HepVu. First, on the left, you see the narcotic or drug overdose mortality rate, which is the number of drug overdose-related deaths per 100,000 people. And then you see the opioid prescription rate, which is the number of opioid prescriptions dispensed per 100 people, and the prevalence of pain reliever misuse, which is based on national survey data from NHHAD. And of course, you see each of those mapped at the state level. And the shading for the maps is darker for states with higher rates or percentages for a given indicator. And so here you can kind of see what I mean by putting these data side by side, right? All of our hepatitis prevalence and mortality maps can be shown alongside these opioid indicators or alongside the social determinants of health that I talked about earlier. And what you can see from this particular comparison is that the hepatitis C burden of disease tracks pretty well geographically with opioid-related morbidity, particularly in states in Appalachia. So this is just one example of a story that you can tell with a side-by-side comparison maps, but you're able to compare maps of your choice on the site, download them for use in a presentation, print them, or you can even embed your comparison directly onto your webpage. So there are just, these are just a few ways that you can find and follow us on HepVu. I really encourage you to follow us on social media so you can be the first to know about new data releases and resources. It was great to be here, and I thank everyone for attending, and thank you, Luis, for having me, and I'll turn it back over to you.
Thank you, Dr. Bradley. It's always a pleasure to have you here explaining such an important website that I surely visit frequently, and I definitely have used those infographics, some maps in some of my presentations. They are very didactic, very easy to understand. So I encourage everybody also to do the same. So I also ask the audience to please ask your questions, write your questions in questions and answers, or in the chat box, so I can read it to the doctor. The data that you show says that baby boomers are 71% of the people who's living with hepatitis C. Is there any reason why the baby boomers is the population that is more affected? How can we explain that?
Yeah, we think it's mostly a result of medical procedures that were conducted before the time that we regularly screen the blood supply. And so, of course, now the blood supply is routinely screened. And so you would have negligible risk for an infection like hepatitis C if you had a blood transfusion, for example. But people who, live or are in this birth cohort may have had risk related to contaminated blood supply before we had regular screenings, and then other, sort of medical procedures that were done at a time before we had really good infection control practices. Unfortunately, the new infections that we're seeing, are much more likely to be as a result of unsafe injection drug use practices. And of course, some of those happened among the baby boomer cohort as well, but we think most of those infections were due to subpar infection control practices.
Interesting. Adrian Juarez is asking, were there enough Hispanic survey takers in the states with low Hispanic populations, for example, Appalachian states?
I'm sorry, could you repeat the first part of that question?
Yeah. Were there enough Hispanic survey takers in states with low Hispanic population, like, for example, in the Appalachian states?
Yeah, so this is a problem, right? When we look at these data by race, ethnicity, for most, for many other important infectious diseases, we have reliable reporting systems, right? Where states are required to report infections, and there are regulations around reporting race and ethnicity so that we can look at these disparities, and hopefully start to do something about them. For hepatitis C, we really even at HepVu are relying on modeled estimates because of the lack of good surveillance data, and in particular by race and ethnicity. And so it's a really good point. When we look at hepatitis C in Appalachian states, we're really only able to look at the state as a whole. Or, in the case of our model, we were able to compare Black Americans to non-Black Americans, right? But we're severely lacking in data on hepatitis C burden of disease, as well as mortality among the Latinx population. And so this needs to be, a major priority for research. And I think we all need to be advocating for better hepatitis surveillance, certainly, because we know that hepatitis C leads to many adverse outcomes in the Latinx population.
Yes, you mentioned that Latinos do not represent a big portion of the people living with hepatitis, but we know that within the Latino community, there's different populations. We are from different origins,
Right.
different countries, different everything. So we are not a monolithic
Sure.
community. We are different groups. And we know that among Hispanics, one of the groups mostly affected by hepatitis C are Puerto Ricans. When you show the map about the data, county data, Puerto Rico was white. There is no information there.
Yeah.
There's no reason why there's no information on Puerto Rico.
Yeah, it's because we don't have hepatitis C mortality measured there with the survey that we used. So again, points to a major hole in the hepatitis C surveillance among the larger Latinx population and Puerto Ricans specifically.
Yes. Suzanne Stroff-Burgol asks, how you define hepatitis C related mortality? Hepatitis C positive, but what if death occurs because of an overdose in a younger person? Do you count that as related or not?
So, on the death certificate, this is in a very imperfect way, I will say, of recording cause of death, right? But on a death certificate, the coroner or whoever is filling that out can fill out up to 3 causes of death, right? And so there's sort of a primary cause and then an underlying cause and an underlying cause, right? And so let's say you died of liver cancer, but that liver cancer was attributed to hepatitis C. You might have, the primary cause of death will be liver cancer, and then an underlying cause of death would be hepatitis C. And so I'm really glad you asked this question, because in order for deaths to be attributed to hepatitis C, the person filling out the death certificate has to know that that person had hepatitis C, right? And the person's treating physician, certainly needs to know that that person had hepatitis C. We know that about half of hepatitis C infections in our country are undiagnosed. And so certainly there are many people who die of complications related to hepatitis C that don't get attributed to hepatitis C because they were undiagnosed at the time of death. And so this is another, just, as we enter this week of hepatitis, testing awareness day, this is another important reason for providers to be screening their patients for hepatitis C, so that when we do see deaths that are attributable to this infection, they get recorded accurately.
Rachel Greenstein asked, what data sources are you using for both county and state level data?
So for the state level prevalence estimates, we're using the base data sources in NHANES. We're using NHANES in combination with data on drug-related overdose across the country that's geographically specific, and then data from the census on describing populations at the state level, and then these data get fed into a model that sort of estimate prevalence at the state level. At the county level, we're using, and I should also say that there's, for the prevalence estimates, we're also estimating prevalence, hepatitis C prevalence among populations that are not included in NHANES. So we know that people who are unstably housed or people with with substance misuse conditions may be less likely to either be sampled for NHANES or to participate in NHANES. And we also know these populations tend to have higher rates of hepatitis C. And so to account for that, we computed separate estimates of hepatitis C prevalence in these groups and then sort of added them back to the US estimate that is captured in NHANES. And so for mortality, it's a little bit more straightforward. It's a combination of census data and then mortality data from vital statistics. But again, there is a limitation there in that you would only be counted as having a hepatitis C related death if that was recorded on your death certificate.
And related to that, the CDC also reports how surveillance data that CDC releases every year. Is there any correlation? Do you use the data, or do you share data with them and then with you or something?
Yeah, we actually, all of the work that we display on our site has been done in collaboration with CDC. So all of these estimates were funded by through a modeling collaborative that CDC funds, and then we co-published all of the data and manuscripts with CDC co-authors.
That's good to know. I was going to ask the same question as somebody asked. When would this data be available, since it's mostly outdated, like 2016?
Yeah, yeah. Unfortunately, we're sort of have to deal with data lags from the surveillance data sources, but we're looking at potentially being able to update the prevalence estimates sometime toward the end of this year. So we're well aware that these are outdated because we use a combination of data sources for the prevalence estimates. We have to wait until there are enough new data across those data sources, but it's definitely in our plan.
Also, it was mentioned that mortality in Hispanic is higher than in other groups. Is there a reason why the mortality is higher? I know this is just statistical, but maybe doing the work you find out.
Yeah, I mean, I'd be interested to know sort of what you think about that as well. I think, I mean, we know there are access to care issues, right? I think a lot of sort of racial and ethnic disparities don't actually have anything to do with the ethnicity of the person. It's just got a lot more to do, unfortunately, with underlying factors around, around social determinants of health, like income level, education level, and really it comes down to health literacy and access to good quality, testing and care.
Thank you. Jose Santiago Velez is asking, it is great that you were able to map out prevalence with social determinants. I wonder if a risk radio could be calculated based on the convergence of demographic data and social determinants so that we can focus our interventions at the county level, given the regional disparities and finite nature of resources.
Yeah, so I'm sorry, were you asking about mapping the social determinants at the county level?
Yeah, it says like it's great that you were able to map out prevalence with social. So the person wonders if there is a risk radio could be calculated based on the convergence of demographic data and social determinants that we can use for their interventions at the county level.
Yeah, potentially. I mean, I think that potentially is available. We've just really made our first foray into the county level with these mortality data in the last couple of months. So we're really just starting to explore sort of the suite of data and resources that we could be providing at the county level. And some of these opioid indicators are also available at the county level. And so we're starting to think about, now that we have our first hepatitis C data at the mortality level, what kinds of county level comparisons could we be making? Because I know that, having those data at a more granular level is really important, especially for people who live in large and diverse states.
Michael Mercado is asking, do you partner with the specific agencies to assist in advocacy for hepatitis C screening and prevention? Have you seen your infographic charts being used in the realm of advocacy or prevention at the local level?
We partner with a number of advocacy organizations, but we're always looking for more, people to bring under our tent or to squeeze under their tent. I think, we do a lot of work, for example, with NHHAD. We do a lot of work with the National Viral Hepatitis Roundtable, and they do send us reports of, when they do Hill visits, what they were able to take along with them and what was effective and, what worked well. And often they'll come to us and say, like, we're doing an advocacy week in 6 months, and here are the kinds of things we could really use. And so they're actually providing input to us around what would be helpful for them to take to the Hill. And so I highly encourage those of you who are part of advocacy groups or policy groups to reach out to us. Let us know, what kinds of resources will be helpful for you. And like I said, we're always looking for more advocacy and policy partners.
Kevin Sanders asking, he would like to know that when HepVu look into the African-American population, is there anything in the data that you collect that distinguish between the people who were born in this country and the people who came from other countries?
Yeah, it's a great question. And unfortunately, this is another one I have to answer with, data not available. I think, we have some data from NHANES on country of birth, but unfortunately, when you're modeling estimates, the smaller the population size, the harder it is to get a stable estimate. And so if you think about, the first priority for us is to map estimates at the state level, and then we go down from there and say, how many other ways can we slice and dice these data and still have robust estimates? And so, I agree, this is a really important question that unfortunately we don't have enough data to support right now. But when you look at a surveillance system like HIV, for example, it's a different story. They have really good completeness on race data and many more abilities to really sort of drill down on what the risk factors are for infection. And so I think, the moral of the story is we all have to keep advocating for more resources and better funding for hepatitis surveillance so that we can start to really get a handle on what is driving, a higher burden of disease in certain populations.
There's a comment or suggestion, I guess, from Wayne Cosby. He says, under resources, you should have HealthWell or PEN Foundation for patient deductibles. Also where to find affordable labs. Great website, but if you want to be a one-stop shop, it needs to include these resources.
It's a great suggestion. And we actually are starting to think about adding some additional locators for patients on the site. It's something we've been working toward for a while. We have, for example, on AIDSView, our sister site, you can see on a map, where there are clinics to where you can access PrEP, for example, or HIV testing or care. And so ultimately, we have goals to do that same type of mapping on HepVu. Again, unfortunately, the data are not compiled in as sort of organized a way as they are in HIV. So we've got some limitations there, but I completely agree that, particularly for HepVu to be, more useful in the patient population, we need to be adding additional clinic locators and information to help navigate care.
There's a question from an anonymous attendee, and he or she would like to know more about the webinar that you're having tomorrow. So I will ask you, maybe you can write the link or the information in the chat box so everybody can have it.
Oh yeah, absolutely. I can definitely do that.
That's great. And also there's a comment from Susan again, and she said, thank you very much. So most likely Hep C related mortality is underreported on the death certificate, since that might not include the Hep C diagnosis if, for example, the certificate is filled by a coroner or somebody who doesn't know the patient really.
Yeah, that's right. Hepatitis C related deaths are definitely underreported. There's no doubt about it, because first of all, we may not know that somebody was infected if they were undiagnosed. And then, as you know, reporting practices, you probably, I mean, I'm guessing, you know, by virtue of this question, reporting practices differ from practitioner to practitioner, right? And so we don't have a great standardized way of reporting hepatitis C related mortality. But I think, you know, one easy opportunity for improvement there is more screening, right? Is that providers are screening their patients as appropriate for hepatitis C, so that it ends up in their chart, you know, and frankly, so that they can be cured and not die of hepatitis C related conditions. I'm looking for this.
Yeah.
I'm looking for this for you right now. If I have anybody from Signal on the line who could put the link there, that would be great.
Or you can send it to me by email and I will forward to everybody who attended today.
Okay, that would be great.
Oh, there's Signal.
Thanks, Chelsea. I thought I might get a Signal calling to the rescue. Thank you.
I have a question. Sometimes I look for information on hepatitis B, and HepVu only have hepatitis C. Is there any plan on adding Hep B to the data?
Yeah, we get that question a lot. So we're always exploring new options for both hepatitis A and hepatitis B data. You know, it's sort of like if hepatitis C surveillance is under resourced, hepatitis A and B have, like, you know, twice the issue. And so I think you know, this is something that we talk about at HepVu, I can say probably on a monthly basis. We're actually looking to add some hepatitis A and B expertise to our core team right now. And so I would say, you know, look for more in the future. And if you have ideas for creative data sources, or you're working on a modeling project where you're looking at hepatitis A or B estimates, we would love to talk to you and to amplify what you're doing on our site.
All right, we are reaching the end. It's only 5 minutes left. There's some more questions. I just want to thank you, Dr. Bradley, for being with us again, explaining HepVu and all the data that's so important for us when we do research, advocacy, and our daily job. And I would like to thank everybody who attended today and encourage you to visit the website, which is really, really helpful in everything that we do when we do this type of work. So thank you very much and have a good night.
Thanks, everybody. Thanks for having me.